Good morning, everyone. Okay. Let's start with the third session of what would you do? Third. Today is the third session and the third season.
Temporada 3.
Temporada 3. Okay. Don't forget, follow us on the YouTube channel, Academy Powered by YAT, and to follow our conference. Yesterday, we post these pictures about our case. It's an adult patient, present constricted maxillas, both lower midline is deviated to the right, mandible is deviated to the right, retrocline upper and lower incisor, class 2 canines, both sizes, missing 35 and 46, okay? And our question was, what would you do? Expand both arch, distalize the upper arch, expand both arch or mesialize lower arch, and orthodontic surgery. And the people answer, sorry. Tan, 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 tan. I didn't take the picture for the results. But do you want to see? Joe, I think it's the middle one that win.
Yes.
By far.
52%.
52%.
Yes.
Okay? And let's see. Let's talk about the case. It's a very interesting case. Here you can see it's very notorious that the deviation of the the mandible to the right, okay? I cannot put the whole pictures, but it's obvious like she has a discrepancy on the mandibular rims, okay? It's an asymmetry form. And you can see here, on that point we didn't take the CBCT as we do today, but we have the pantomography to see the size of the rim of the mandible and of the body of the mandible. And it's very obvious the side of the left is short than the right is shorter than the left of the patients. On these cases, we always have to show the patient what is the problem, and we have to propose the patient the treatment plan. If she really wants to straighten the teeth and get a better occlusion, we can do only with orthodontics. But if she wants to show and appear with the same side of the rim of the mandible, she will need a surgery. Okay, the orthodontic cannot recite the shape of the mandible. But obviously we speak with the patient, we show her the two kinds of treatment, orthodontic with orthodontic surgery and only with orthodontics. But she knows what's the limitation of the treatment. She didn't want any orthodontic surgery because she's asymptomatic in this moment, any pain on the articulation. And we, on this picture, she didn't smile too much. We cannot see the deviation of the midlines, dental midlines, but we can see the deviation of the mandible. On the intraoral pictures, we can see a constricted maxilla. We can see the torques of the upper maxilla. It's on the left. You can see that it's more negative torque than the right side. What that means? Where is the deviation of the mandible? It's to the right. If she must be like this since she was a child. And what happened here? That's why I always repeat, that we have to do an early treatment to avoid asymmetric growing. That's why if she had a very simple treatment, very short treatment and cheap treatment, she didn't have like this right now. But she's a growing up, we cannot change the growing, and we have to correct the torque of the posterior teeth. We have to expand, and we have to expand more the left than the right, okay? And create and develop the upper and the lower arch. Okay, we proposed the aligner treatment. In this case, it was with the Spark. We see that we have a class 2, a retognatic mandible. And this was the first orthodontic treatment with aligners. What we did, we expand, we developed the upper arch, and the first goal on this treatment was to let free the movement of the lower arch. What that means, I'm not going to correct the lower midline moving the teeth. I'm going to expand, and I'm going to allow the mandible where are going the movement. Maybe I know that the mandible is not going to be on because we have an asymmetric mandible, but at least the mandible is going to be free. And my purpose was free mandible. We expand, we correct the torques of the posterior teeth, we open space. Why? Because I want a free mandible, as Dr. Shen said.
Free will.
Okay, free will. On this time, the aligner on the lower was 25, on the top was 21. That is very short treatment, is 21 aligners. Of course that we are not going to say to the patient, you are going to finish in 5 months. Of course not. But this is our first goal. Sometimes the complicated cases, you don't need to solve on just the first set of aligner. It's impossible. You don't do that with braces. That's why don't complicate the cases. Try to correct first. You have a goal and let's do it, and then you explain the patient that that's why we are going to do an unlimited aligners to correct the first phase, and then we take more registers to get the second goal of the treatment. On this time, okay, you can see it's a little better, the deviation of the mandible, okay? But we make a big spaces, okay? Why? I started this treatment 2 years ago or more, and I used to be with another brand that it was with Invisalign and make a lot of spaces because the plastic is so different. That's why I came, this is a very long conference, but I'm just bring it here because the difference of the materials, it's very important. Nowadays, the orthodontics just, no, because which brand is better? We need to know the material, what is the difference in a flexible plastic or more rigid plastic and the thick of the plastic. We need to know everything. And in this case, we have this brand that have 2 kinds of material. The True Gen is a material very flexible, and I was used to with a more rigid. That's why I make a lot of spaces. But you can see that this plastic is as much as flexible that make me more predictable movements to make a big spaces. But at least she wasn't too upset with me, but she was much better. She told me that she feels better about the movement of the mandible because we create space, we develop the upper arch, and now we have to get move the midline to the right, okay? And we take the new registers, we finish the first phase of the treatment, and now we are going to decide what we are going to do. That's why on this case, we decide to mesialize the lower teeth, okay, and get a bigger space of the teeth that are missing is the lower right molar and the left lower premolar, to get a better relationship between the canines. We need to get a better canine guide, okay, to avoid any occlusion interference, and we did with more 5 months, 29 aligners. Okay, this is the X-ray. We have the space to intrude. You need to know with aligners we need space to intrude the teeth. And we finished the 25 aligners. On this part, okay, we need to evaluate. We didn't get enough intrusion of the 21 on the 11, and we need to finish in the case. Okay, as a braces, I don't know, fixed appliance, we need to take time to do the finishing with perfection. With aligner, it's the same. We need to go, we need to do, okay, it's here. This is the third approver that we finalization get 5 months as the first phase, and we did the finishing. We intrude, we get we open more the deep bite, we procline more the lower teeth and mesialize the lower arch to get a better occlusion. We expand and expand. We did 3 times expansion, lower, very slow expansion, bringing the roots, the palatal root torque, and bringing the crowns more expand. But you can see on this time, we are working for perfection of the midlines. We're moving teeth. We put the midlines on, we expand, we create. What's the problem? We have a recession on the 42. But now we do a new scanner and a new register. What? To do what? To give torque, root torque, lingual root torque to that tooth. And we know that is going to solve. We don't need a periodontal intervention, okay? And that moment, we finish, look at the profile, it's get better. The position of the upper incisor according to her nose, she is retrognatic maxilla and mandible. We don't change position of the maxilla, but at least we put everything on balance, okay? We finish with 9 aligners, okay? It was the last phase according to the rehabilitation and the surgeon to put the implants to get a better occlusion. Look at the root torque of the 42. You don't need any attachment to do that. You just need the plastic push more near to the center of the resistance to bring back the root. And at the end, we have a very wider smile with no recession of the posterior teeth because she didn't have a constricted of the bone. The problem was, like I said at the beginning, she had a negative torque on the crowns of the premolar and molars. And you can see it's much better on the picture. We cannot see. It's much better the recession of the gingiva, okay? You can see here, it's getting better. It's going to get better because she was going to continue using the retainer with a little bit of pressure of the crown, of the root, but she is ready to put the implants. She can go to the surgery, she get a better occlusion on the premolars, on the canines, class 1 molar, and she put the implants. Now, she put the provisional crowns to do. I need to stabilize my occlusion. I need to look at the recession. Just with the liner, not any, of course, very good oral hygiene. We have to show the patient that she needs to clean the recession, because always with that kind of recession make a room for get a lot of food. Okay, we need to show her to do massage on the gingiva, and we get this result. And that's it. I don't have, now she's wearing the last aligners to keep the occlusion. And any questions?
Oh.